Hello, you're listening to the recording for the assessment of the digestive and gastrointestinal function. By the end of the recording, you should be able to describe the structure and function of the GI tract, explain the mechanical and chemical processes involved in digesting and absorbing nutrients, as well as eliminating waste products, discriminate between normal and abnormal assessment findings identified by inspection, auscultation, percussion, and palpation of the GI system. Recognize and evaluate the major symptoms of GI dysfunction by applying concepts from the patient's health history as well as the physical assessment findings. And identify the diagnostic tests used to evaluate GI tract function and relating nursing implications. So make sure that you know the A and P of the GI tract. The book does go into detail on the functions and patho A and P of the tract. And my lecture is going to focus on assessment diagnostics because you've already had it, but just make sure that you understand the process from the time someone takes the food in until it is excreted. As far as an assessment, you want to begin with a complete health history of the GI tract. So you're going to focus on history of the GI system. Make sure you ask about childhood as well as adult issues whenever you're going over the health history. Pain can be a major symptom of GI disease, so make sure you complete a thorough assessment of pain if they're complaining of pain. Ask about the pain. Is it related to mealtime? Is it always before a meal, after a meal, or is there really no specific cause as far as it being timed? Does it happen during rest or during activity? How are bowel movements related to pain? Are their bowel movements regular? Have they changed? Has the consistency changed? Has the timing changed? Has the amount changed? And because that can play a large amount in the cause of pain as well. They could be having cramping from either loose stools or from constipation. They can have referred pain. So referred pain means that there is something going on somewhere in the body that's triggering pain. However, you're not feeling it in that spot. So patients who have gastric regurgitation or GERD will complain sometimes of having pain in their heart or left-sided pain or right-sided pain up in their chest when it's really acid reflux. So there are different types of pain that can be referred, and that just means it's felt elsewhere. Dyspepsia is indigestion or pain, discomfort. Sometimes they complain about bloating feelings of fullness. They might say that they have heartburn or regurgitation, and this generally occurs with eating. Nausea and vomiting can come from a variety of causes. And it's good to keep in mind that vomiting, as well as diarrhea or loose stools, is a protective response. And it's your body's way of trying to eliminate the noxious agent from the body. So you don't always want to prevent or prohibit that from happening. Always look at their bowel habits. What is their bowel pattern? Do they have daily bowel movements? What is the color of their stool? What's the consistency? Any odor outside of what would be considered normal for them, as well as the amount. And it's important to know what it looks like, the consistency of it, not only to see if they have diarrhea or constipation, but also if you have some sort of parasite or if you have a GI bleed, if you have any kind of bacterial infection, then that can change the consistency, the color. It can have mucus in it. They might see worms, but you might not see worms. But you'll notice that your stool is more ribbon-like, and that can be if you have cancer. So the consistency is very important in helping to determine what would be the cause of the GI disturbance as well. You're also going to look at family history. You're going to be looking at parents, grandparents, aunts, uncles, brothers, sisters to see if there's any kind of familial GI disorders or dysfunctions. And then social history. Do they eat out a lot? Do they eat at home and cook at home? Do they smoke? Do they drink alcohol? Do they do it all the time or just whenever they are out? Do they have dentures, missing teeth, lesions in their mouth? That will all determine their nutritional intake. If they aren't taking things in, they can't really excrete them back out. So, like I said, important to start from the mouth and work your way down. As far as looking at the lips, you're looking for moisture because that will tell you if there's any dehydration. You're going to look at the color, texture, and symmetry, as well as presence or absence of lesions. Look at the mucosa and the tongue. Again, color, lesions, any kind of edema, swelling. Is there extra redness or is it pale? You're going to assess gag response, gag reflex as well. You're going to look at the uvula, at the adenoids if you can see them. An abdominal assessment, you're going to look at all 4 quadrants. You're going to look initially, and then you're going to listen, and then you're going to feel. So inspect first, then auscultate, then percuss and palpate. If you percuss and palpate before you auscultate, then you're going to move the air around. And so you can either get absent or hyperactive bowel sounds just from the manipulation. And it isn't actually what their bowels normally do as far as assessing the peristalsis. And then you can inspect their rectum. Sometimes you can see hemorrhoids if they're external. You're also looking for any lesions and then color. As far as diagnostic tests, they can do serum labs, which is a venous blood value through the phlebotomist. CBC, CMP, PTINR, PTT, triglycerides. They'll look at liver function tests because that can affect your stools, amylase levels, lipase, alpha-fetoprotein, and then for cancer screenings, they'll do the CEA and the CA. Those are just screening tests that they can do. You can have stool tests, and you can just have a regular stool sample that is assessed for consistency and color. You can get a fecal occult blood test, and that can be done at the bedside or it can be sent to the lab. That's testing for any type of blood in the stool. You can look at a fecal urobilinogen, a fecal fat, nitrogen. You can test for C. diff, toxoids, fecal leukocytes, any type of parasites or other foreign pathogens that are in the stool. You can look for food residue. You can get an abdominal ultrasound that is non-invasive, and it basically will look at the abdominal cavity to see if there's any enlarged gallbladder, pancreas, if they might be able to see gallstones, just because of the stones will be a different density than the gallbladder and the bile ducts. Any enlarged ovaries, which can trigger GI symptoms, ectopic pregnancies, which will trigger GI symptoms, and appendicitis triggers GI symptoms as well. They can do an endoscopic ultrasonography, and that will visualize the GI tract, but it is invasive. The patient will be put under moderate sedation, and then a scope will be put in going through the esophagus, and that can help with diagnosing submucosal lesions, Barrett esophagus, portal hypertension, chronic pancreatitis, biliary tract disease. It can also look at changes in the bowel wall that might be caused by some sort of ulcer. Scintigraphy is whenever you have a blood sample removed from the patient, you mix the blood sample with radioactive substances and then re-inject the sample back into the patient. And the radioactive substance actually tags the red blood cells, so it sticks to the red blood cells and the leukocytes. And then it's tracked, and they do imaging, and they'll be able to see the radioactive tags. And this is used to detect inflammation. Maybe if there's an abscess, it will detect an abscess. Any place that there's blood loss, if they have a GI bleed that they're having trouble locating, then this will help to track that because it tags the red blood cells that will then be leaving the GI tract where the bleed is. Can also help to detect neoplasms. You can get upper GI study, which is a fluoroscopy that's used for patient after they ingest a contrast, and it can be used to diagnose anatomical or functional disorders of the upper GI organs. It also can determine sphincter control or loss of control. It will help determine any lesions. If there's esophageal varices, it can detect that. Any kind of tumors or benign or malignant growths. Enteritis, malabsorption syndrome. They can take the scope, go through the esophagus all the way down into the stomach, and then extend it into the duodenum if they need to. And there they can look again for any kind of lesions. They can also see any obstructions that might be there, whether they're partial or complete, or strictures. Ileitis, diverticular disease of the small bowel can also be detected. If they are getting an upper GI tract study, then the patient will be NPO from midnight the night before, and all medications will be held that morning as well. They want everything as empty as they can possibly get it. After the procedure, the patient's encouraged to drink fluid so they can push through the contrast. Otherwise, if it stays in their system too long, they'll get constipated and they can't get a blockage if they aren't able to pass it. Lower GI tract study, generally the patient's given a barium enema, so instead of swallowing the barium, they'll actually inject it via an enema. And this can be given to detect the presence of polyps, tumors, or lesions of the large intestine, also around the perirectal area and just inside the rectum. Can also detect anatomic abnormalities, any kind of malfunctions of the large bowel. If you do have a patient getting lower GI tract study, they're going to be on a low residue diet for 1 to 2 days prior to the procedure. And then the day or afternoon before, they'll be on a clear liquid diet. They'll be given laxatives the evening before. Up until midnight, they will be NPO after midnight, and then you'll give cleansing enemas until the enema runs clear. And that'll be done before the procedure so that you can get everything out of the large intestine that you can. And then after the procedure, again, push fluids because that barium can cause constipation. If it stays in too long, it can actually cause an obstruction. Gastric emptying studies, the patient is given liquid and solid components of the meal after they are tagged with radioisotopes, and then the patient's scanned over a specific time frame to see how long it takes for the food to move through the GI system. An EGD is used to evaluate esophageal and gastric motility, can also be used to collect secretions and tissue specimens, and to help diagnose inflammatory, neoplastic, or infectious processes. An ERCP is done, and it's a scope in combination with x-rays to allow the physician to view the bile duct, the pancreatic ducts, and the gallbladder. The only downside, it can also remove different stones if they find stones in the bile ducts. The biggest downside is it tends to cause pancreatitis. So if they're in for one condition, they get the ERCP. It is not uncommon for them to then get pancreatitis. So then you're treating them for a different disorder. As far as nursing procedures go, interventions, most patients are NPO for 8 hours prior to the exam. So if they have an exam late in the afternoon, they don't have to be NPO from midnight on. It's just 8 hours. Since they are getting an endoscopy, they will have some sort of anesthetic gargle or spray that will help to numb the esophagus, and then they're also given Versed. They can be given atropine if they have a large amount of secretions, and then glucagon can also be given to further relax smooth muscle if that's necessary. Post-op, they will be under moderate sedation, so you'll follow the moderate sedation interventions. A colonoscopy is a direct visualization of the bowel itself. It can be used as a screening tool, or it can be used as a diagnostic tool. And the success depends on how well the colon is prepared, and this is when the patients will do bowel prep. Bowel prep can vary. GI physicians and surgeons are pretty particular with what type of bowel prep they like. But in general, they'll get laxatives for 2 nights prior to the exam. They can get a fleet or salines enema until it runs clear the morning of the exam. They can also get electrolyte lavage solutions like the Go Lightly, and the patient will start with a clear liquid diet at noon the day before the exam, and they'll start to ingest that oral lavage solution, and they should drink an 8-ounce glass every 3 to 4 hours until what they are excreting from their GI system is clear. This is how they will sit, so they will be in the left side lying position, and the nurse will be responsible for putting them in that position. It can be done outpatient at an ambulatory care center, or it can be inpatient. You want to ask the physician about routine medications, if the patient can take those medications before their GI procedure, especially if they're cardiac or diabetic medications, or if they want to hold those medications. And then make sure you do good post-op teaching in the pre-op setting. Any restrictions they might have post-op, they need to be aware of that during pre-op, as well as making sure that they understand what procedure they're getting. They do have informed consent signed, and then if there's any kind of anxiety or discomfort, then you can help with that. And then, before, during, and after, make sure they have adequate hydration. If there's pain, make sure you address that. Answer any questions they might have. And if you have anything abnormal that comes up before the procedure, then it's your responsibility to make sure the physician knows.